not know that the National Alliance on Mental Illness. And NAMI Tri-Valley serves Livermore, Dublin, Pleasanton. So what a perfect match to have our police chiefs here tonight. So I just wanted to take a couple of seconds here to let you know that NAMI Tri-Valley's mission is to partner with and collaborate with other organizations so that we can provide support, resources, educational outreach, and advocacy for anyone whose life is affected by mental illness. That could be the family member, that could be the individual, that could be a whole community. So we are here. We're not going anywhere unless somebody finds a cure. We are here. So I do want to also mention a couple of events that we're having. We are so busy in a very happy way. We have our 11th year providing suicide prevention workshop for family caregivers. An 8-week course on family to family, which is an educational and structured class for any family member who would like to know more about mental illness. There's a very comprehensive course. Everything that we provide is free. We do have monthly guest speakers, and we're very proud to announce that we're going to have Dr. Karen Tribble, who is the director of Alameda County Behavioral Health, and will come to us on Zoom only. And she will update us, particularly now with changes, how that will affect us locally. The other thing that we'll have that night will be through the Indigo Project that wants to hear from us, the community. They want your voice. This will be a half hour before the Dr. Cribble's talk. And they are looking to put together information to combine mental health and behavioral health and make it in a whole different, I guess, I think a more efficient way of dealing with individuals with substance use disorder or mental illness or a combination of the two. So it'll be all put together in one package. They want to know what we think about it, and they also want to know, they want to name it. And so those of you out here who are interested, and please, I hope everyone is, the politics, we don't need mental health help out here. That's the politics. Why don't we prove them wrong? Because this is our beloved county. And if there's anyone here from behavioral health, okay, I would love to talk to you about that. It's been 10 plus years of bringing that message home. So anyway, we are very pleased that they did reach out this time, first time in years. And so with that, I do want to thank you, the audience, for being here. Those who are on Zoom, thank you as well. And then I especially thank the police chiefs who are here tonight. You are very, very important, and we do appreciate that very much. And with that, I'm going to hand this over to our second vice president and speaker coordinator, Armine Matetsi.
Thank you, Marcia. Welcome, everyone. Special welcome to our chiefs. I would like to announce the couple of special people amongst us here before I get started. We have from Pleasanton City Council, Jeff Nybert and our own Julie in the back, but you'll hear Julie's name in a little bit again. Also from County Supervisor's Office, Valerie Arkin. So welcome, there she is in the back. Welcome to all of you. When we plan these events, we really don't know the turnout, but we want public to have this unique opportunity. So, but before we get started, and my goal is to turn this to the discussion as soon as possible, I do want to take a minute and thank two special people, actually 3. You heard from Marcia. Marcia, our president, founder of NAMI, 20+ years, and we're kicking and we're not going anywhere, as you heard. I would like to also acknowledge this discussion that wouldn't have happened without these two special people along with Marcia. Our own board member and the city Pleasanton council member, Julie Testa, in the back. Let's hear it from her, okay? First, Julie has negotiated. Yes, she negotiated with the chiefs and proposed a possible site. We all talked about it, we dreamed about it, but she kept persistent and her dedication made this happen. So, but I cannot forget the very special person here, Queen. Did you see her sitting? Queen News, our admin, and she is the glue that brings us all together. So we're very grateful. So with NAMI Tri-Valley is honored to present this very unique event. I believe this is the first of its kind where we have 3 city chiefs, and all of us here, we have our own stories, but we're really curious to hear about very, very special topic to our hearts. Okay, this is so I get emotional just to think about this, okay? Psychiatric crisis for our loved ones. So without the further ado, I'm going to say a little bit about the agenda. We will have each chief speak about 10-15 minutes. We want them to introduce themselves. I am not going to take their thunder. I keep on talking, but it's not about me. All right. So we have from Pleasanton, Chief Tracy Avalar. We have Chief Jeremy Young from Livermore, and we have Chief Victor Fox from Dublin. All right. So they'll each get a time to present what themselves, their teams. Once they're done, we have planned a little pre-planned questions that I will carry that discussion with them, and then we'll open up. We'll have plenty of times for everyone in the room and online if we get some questions. Online people cannot ask, but we encourage to jot down your questions, and Quinn will read it for you. Okay? So that said, I'm gonna pass the mic to Tracy.
Thank you so much, I appreciate it. I am very happy to be here, but I am not the star of this show, and it actually should be our team sitting here, and we should be over there applauding them, because as you will see, when the questions start flowing, these are the experts over here, the heroes over there. So my name is Tracy Avalar. I am the Pleasanton Police Chief. I've been here since late last year. I came from Foster City, where I was the chief for 5 years. The more time I spend in policing, the more we figure out that we cannot do this alone. So it's been a really shared effort, especially for this ARU program that I came into, and it really is an incredible group of people that are involved in this. So this is called the Alternative Response Unit for Pleasanton. It's award-winning in 2023, the Helen Putnam Award for health and wellness programs. They pair a licensed clinician, licensed as a, is it official today? She's got her license today. So a licensed mental health clinician with a non-uniformed police officer. And you will hear the training that the police officers receive. Tonight I'll let them tell you about that. But introducing, so it's clinician Julie Snipes, Officer Ricky Barcelo, and Officer Ryan Tujay. So the mission of ARU is the acronym that we use, is to provide appropriate treatment and resources to individuals experiencing a non-criminal mental health crisis, and to provide resources and referrals for those experiencing homelessness. They respond to calls involving behavioral health concerns, checking on repeat callers, do proactive outreach. And this model helps us divert people away from the criminal justice system and towards services and care that they really need. So while the program is not set up to handle a caseload, there is a focus on connecting individuals and their families to long-term care and solutions. This program launched with the recognition that not every 911 call needs a traditional law enforcement response, and to avoid the use of involuntary psychiatric hospitalization when appropriate. And as many of you know, when someone is in crisis, the presence of a uniform can escalate things unintentionally. So having a clinician there, leading with empathy and clinical expertise makes a huge difference, not just for the individual and their families, but for the outcome. So thanks again for the opportunity to be here, and I look forward to the conversation.
All right, my name's Jeremy Young, and I'm the chief of Livermore. I've been in law enforcement for over 30 years, and I've seen a lot of changes in my time. And I also wanted to thank NAMI for organizing the event tonight. I know it's mental health is a huge issue, and we deal with it every day. And I also want to thank the team over here who is really where the rubber meets the road, and our clinician Lily is with us. And the officer, Andy Greghart, is on vacation tonight, so he's not with us, but they are the pair that go out there and really do all the service and the hard work. We started our unit in 2024, and our model really came after some research and things like that, and we decided to hire a clinician in-house and a paired officer who will work permanently with our clinician to go out and start building relationships and deal with mental health issues in the field. And so when they're working, they are the first to respond to the calls that are related to mental health. And in 2024, when they started in January, that year, for the whole calendar year, we had about 2,400 calls that were listed as mental health related. So they could have been a disturbance, but there was some aspect of mental health issues there that were noted. So they're very busy, they're very active. Their goal is to go out there and be the first responders. And Lily takes a point, usually is the first one to make contact. The officer's there to help make sure she's safe. And that's been very effective. They will also build a relationship with somebody that they're normally deal with in the community. And we've seen success in that as well, having those long-term relationships where they can recognize people, know what the situation is, and there's a level of trust that's very important. So they're very good at going out, making sure that we stay up to date on issues that are going on with the particular people that we're dealing with. That has been helpful as well. So we're going on about 18 months of alternate response unit, and we've seen a lot of progress. Unfortunately, I think for me and maybe some who are the professionals in the field, my biggest concern is the lack of resources at the end of the line. And so I think we're doing a good job in the field, triaging, getting there and resolving crisis, maybe keeping people from crisis to some degree. But I would love to see more services at the end of the line so people can really get some good treatment and we're not constantly putting Band-Aids on these issues.
Hi, everybody. My name is Vic Fox, and bear with me. My allergies are crushing me this summer, so I'll do my best. I've been with the sheriff's office since 2002, so I've been in the business for a little bit, and there's been a lot of change in this profession, and we've come a long way when it comes to this topic, but still not enough. There's still a lot we need to do. I've been the police chief in Dublin since October of last year. I'm actually a division commander with the sheriff's office, so it's an assignment for me. But our model over in Dublin is we have a behavioral health unit, and that was established by it was authorized by City Council in 2021 and came to fruition in 2022. And it consists of a licensed or a supervising clinician and 2 therapists right now. We have funding for a third. We're trying to fill that right now, and we're hoping that when that third one gets filled, that we're going to actually have a mobile crisis team. Right now, our team provides no-cost mental health services for Dublin residents, mainly on referral from our school resource officers, follow-up from patrol calls. They follow up on 5150s individuals to make sure they're getting the right services. But it's mainly individual couples therapy, but they are also available for crisis intervention when they're not carrying a caseload, because they are receiving clients most of the day, and clients that typically are stable and will benefit from 10 to 20 sessions. Those who need a higher level of care, who may need medications, maybe inpatient intervention, we refer them to the right services in the county, be it Access Health or Access, to get them to the services that we needed. We're a work in progress. I'm hoping in the next year we'll fill that last spot and be able to respond in the field like Livermore and Pleasanton do.
You hold on to it. As a matter of fact, the mics are supposed to be further away, so pass it down in case there's a back ankle. Yeah, I'll hold it right. Middle person gets to hold it right. Thank you all. Okay, we know that our police officers are the front line to our loved ones. Okay, whenever we're in crisis, they're there for us. So I want to start with a very simple, basic question, and most of us have asked that, and if you dealt with the situation, is how does the crisis team officers determine if 5150 is needed? Is it the same everywhere? Is it different in different cities? No matter what the rules of policy says, there's always room for interpretation. So again, the way we'll do this, if you have the answer, you want to answer it, you can just pick up the mic, raise your hand, and not everyone has to answer it, but we want to hear from all the cities if possible. If it applies to you, feel free.
Well, I'll give it a shot, and then Lily can correct me, because I'm sure she will, but you know, the criteria is the same in the state of California, and so it's almost the same as when we go out and make an arrest. We know we need certain elements for 5150 holds. We also need those same elements, that somebody is a danger to themselves or others, or gravely disabled, and so there's a lot that goes into that. But for a police officer with the level of training that we have, you know, it takes a pretty high bar for us to take somebody as a 5150. So I know a lot of times there's some conflict, because families want us to be able to put somebody on a hold, but we're taking somebody's freedom when we do it, and so it does have to be a pretty high bar, and sometimes it's frustrating to the families, but it's what we're required to do.
So in that answer, I want to hear from you too, Tracy, but just quickly, there's a lot goes into that, right? And when you approach a person, you don't know what's going on, right? And there could be mental illness, psychiatric episode, plus there could be substance use. So many things can be there. How is that determined? What's the difference between like substance use, mental illness, and all of that involved? I just want to understand a little bit more details.
Yeah, I'm gonna send this to Lily, because when I did it, it was about 20 years ago, so she gave me.
I looked them up.
You just tell me who. To answer that question, I think that there's a variety of elements, right? And according to, right, so 5150s or 5585s for minors, it's very complex, it's grounded in state law, but it's also grounded and expanded upon case law. And most people don't study that case law, but the case law is essentially saying that when you're looking at someone and whether they meet that criteria for 5150, you're really looking at the behaviors that you're seeing in front of you. So you may not know in that instance whether it's substance use, whether it's a medical crisis, or whether it's mental health episode, right? They may have no diagnosis, they may have no history. You're just looking at those articulable facts in front of you. Are the behaviors that they're demonstrating at that moment basically meeting that criteria for danger to self, danger to others, or disabled? So that's how my officer partner and I determine that. Now we're trained in a different way, and we also take the time to do a full assessment and really kind of tease out that history, whether it's with family, bystanders, or even just looking back in a history from our prior contacts with them, or looking them up in mental health systems in order to figure out if they have prior hospitalizations or anything else that can help us. So it's very complex, and I think for an officer just out in the field in that moment, they're going to be looking for those behaviors that articulate an imminent danger. team of themselves or someone else.
Thank you.
Julie, can you speak to safety plans and things like that to where you may not need to do a 5150?
Yeah, so I think one of the major purposes of our alternate response or MET programs, right, is that we actually want to reduce unnecessary hospitalizations. Alameda County has the highest number of hospitalizations for C150s in the state, and a large purpose of these programs is to reduce that. And one of the benefits of having a clinician, as opposed to just a patrol officer respond to these psychiatric emergencies, is that we just have so much more training, like thousands of hours of training in mental illness in order to fully assess what is going on with someone, both in the moment, those signs and symptoms that Lily referred to, but also history, if we can get it. And essentially, I'm determining kind of a lethality assessment or risk assessment, right? Of, is this person in such imminent danger that the only safe option for them is to go have their rights taken away and go sit in a hospital under supervision, or I think really the core of why using a clinician is so beneficial is because we have the time and the training to be able to do that, whereas officers, that's just not their role. Yeah. So that answers it.
So I want to take this question further by saying, okay, 5150 is for psychiatric crisis, right? There's a lot of times that a loved ones may be taken to jail versus the hospital. There are three options. When the officer comes, they can determine and say, there is a problem, they calm the situation down, they leave, they can't do anything. Or they can take the person to the hospital, which in our case is John George, all of us know it, all right? Or if there's any physical evidence of illness, they take them to a medical hospital for evaluations, right? And or the third option is jail. What determines what's the outcome going to be? I've seen cases where it could have been either way. I've actually seen a case where the police escorted the person to their home, they calm them down, even though it was cold, and then other times hospital, jail, it could have been either situation. I want to hear from the chiefs and from the experts here, how do they determine that? And needless to say, it's tough situation, they gotta make quick assessment.
Right, I will just say that all of the questions that we will be talking about, this is a gray area. There is zero black and white, as I'm sure you can all understand. So to say when and how is very, very, very difficult. But what the goal is to get people the help that they need. If you have a juvenile or an adult child, say in the house, and they assaulted their parents, the parents call the police, we go there, I don't want anything done, I just want my child to get help. They're not going to jail. If you have a situation where there's a crime that's committed, but the person is in crisis, and so the best place for them is the hospital, not jail, then they're probably going to the hospital. If you're dealing with a situation where you have a victim who is like, hey, I want, so you might have hospital, then jail. So I will let them speak to the field work that is going on, but it's such a gray area, it's really hard to say this and then this and then this. So this overview, you guys. You have a good idea.
Hi, everyone. I'm Ricky. I'm a police officer with the city of Pleasanton. I'm the newest member of ARU. So I'll just speak based on my experience. Oftentimes the way we work is that we don't go to dynamic situations. So usually if there's some kind of crime element, there's some kind of exigency, we let patrol officers actually go deal with that until the scene is safe. And that's when we typically we'll show up with a clinician, and then we'll kind of assess everything that's going on there. So if there is a criminal aspect to an incident, then we'll investigate that. There's only a few times in the law where we shall make an arrest. So an example of that is, say that there's elder abuse allegation. We show up, the elder is clearly being abused as marks. But he states that, hey, my son has been off his meds for quite some time. Our goal isn't always to take someone to jail or, you know, force them to get treatment through county means when they have resources assigned to them. So our goal is to just have a safe outcome for everyone involved. So in that circumstance, you know, we have a duty to investigate. We have a duty to report that to APS, but also we have a duty to care for that other person, right? They're in mental crisis. We need to evaluate that. We do our evaluations, and so what typically happens is we will enact 5150 if they meet the criteria. Sites, the county facility, and then subsequently a report will be taken for that crime, and then they will notify, then go to their thing. But we would also note in our reports that there is some kind of element. Maybe diversion is an option, but we do have to address that criminal aspect. It usually isn't either or, they kind of are all together, and we just try to look for the best solution for everyone involved.
Any comments from you gentlemen on this?
Yeah, I would say it depends on the situation. There's a lot of ways to go about it. So oftentimes there is a crime and there's a mental health crisis, and the mental health crisis has to be dealt with first. So if it's a major felony, or if it's a crime that we shall arrest on, we have to get them to treatment. Oftentimes it's John George, and there'll be a police hold after the treatment's finished. If it's a lower level crime, obviously the treatment's going to go first. That case can go to the district attorney's office. We can deal with it later. Sometimes we have situations where we go to someone's house and someone's in crisis, and there's no crime committed, but they're obviously in crisis. What you see a lot of agencies doing is we have disengagement policies these days. That when we go there and there's no crime, and we've done our best to negotiate, we've checked all these boxes and done our best, and due to AB 392 laws and the use of force laws in California, we have to balance whether further police intervention is necessary. And sometimes if they're only a danger to themselves and nobody else, we have to disengage and walk away. So there's many ways to go about it, but like you said over here, our goal is not to take people to jail, it's to get them assistance, but there's some cases we have to do our job and investigate our crimes.
Okay, thank you. I'll tell you, for my next question, I'm gonna stop here and I'm gonna applaud all three cities with the police departments and efforts. Some of us have been involved in this for years, and about 10 years ago, pretty much none of the police departments had the experts that needed to handle the situation. We've come a long way, okay? So my next question says, so thank you folks on this side. Let's applaud them. Looking for a family member, it's so reassuring that someone comes, it's not in a uniform, and it helps, it calms them down, they talk. So, but that said, so first I have to say thank you. That said, they don't work 24/7. Police is on call 24/7, and we know mental illness, somehow those incidences always happen at the times where it's either night or weekends or, so what happens? How do we address it when there's no backup, no expertise? Are we back to regular service then?
Well, I wouldn't say no expertise. I think the officers are very well trained. They get training in the academy, they get ongoing training, and we've handled it this way in Livermore for all the way up until 2024. And so the officers are well prepared to deal with these calls, and they do a great job on them every single day. So we would definitely prefer to have a clinician team or our med team handle it, but when they're not here, the officers can handle it. Or we will see if the county team, the CAT team, I think it is on duty. We'll ask for them to help sometimes. Sometimes those response times are very long, so we have that option, or we'll send the officers to deal with the call, but in addition to all the things we've already talked about with our Met team and the things that they do, they also provide additional training to the officers during briefing and ongoing training, so all our officers are better trained now since we've incorporated the Met team.
Yeah, just to add to that, our officers are pretty well trained. It's mandated by California Post to do that in the academy, persons with disabilities. For the sheriff's office, when they get out of the academy, they have to participate in the 80-hour jail course where they receive 2 days of CIT training. Officers that come to Dublin from the jail oftentimes have received advanced CIT training. It's a perishable skills mandate through Post that every couple of years officers participate in a 2-hour strategic communications course. I think it was SB 11 in 2015 mandates annual refresher training. So the officers do have the training to deal with CIT or crisis situations. Sorry. Now, the issue with after hours is most of these services end at about 10 o'clock at night. We utilize catalog during the hours that they are working. In 2024, they responded 93% of the time, so it was very good. If our officers are not able to handle the situation, we have a 12-person crisis intervention unit with the sheriff's office. 3 of them luckily work for me in the city of Dublin and have way advanced capabilities to deal with in-progress situations. Oftentimes, we may need to do a full team call out to deal with something that's in progress. But it's definitely something that should happen in the future after hours, because that's inevitably always what we need, that expertise. So I know we're getting there, and hopefully we'll get those resources soon.
Thank you. That's really important to us. All the families, I don't know about the rest of us here, but I can tell you it's usually the weekends and nights. Okay. You really answered my next question that says, what % of officers in the cities have been trained on crisis intervention? So it's part of the training. That's what we wanted to know. And then we can hear from people later on. My personal experiences, I can see the difference year after year. So we're all a team here, and especially us trying to speak on behalf of our loved ones who cannot speak for themselves. And in psychotic episodes, they're more angry, they're more enraged, and then you folks see that it just comes to you, and none of us know how to handle it. So police officers become the soldiers that are handling the whole mental illness crisis in America, unfortunately. So for my next question, I'm going to say the cities have limits, but our loved ones in crisis don't. They go from one spot to the other. They can walk, and I've been told, in psychotic crisis, they can go fast. They can go a few miles, right? So are there departments coordinate from city to city when our loved ones cross the city limits? Is there any efforts or any plans? Yeah, someone that's a resident of Livermore, for example, can be in Pleasanton or in Dublin, right? Who does the records cross, or how do you communicate?
Yes, we're used to working together in all sorts of calls, and this is no different. So we would definitely coordinate, and the information will be available. I don't know if the officers want to speak to that in more detail, or.
Right, yeah. So as an example, if we were out on patrol or as a unit with ARU, if a call came out and we're contacting an individual and they're from Livermore, it's really simple. Hey, dispatch, can you contact Livermore PD and find out the history on this individual right here? And we get loads of information. And so that is utilized very frequently. That is not an uncommon thing that you will see patrol and our unit do, where we reach out, and then if, like, for instance, Livermore, we'll reach out to Lily or even Greatheart directly and say, hey, what can you tell me about this individual? And it's immediate information, and it's a great resource. Yeah, so we do utilize through other departments, and it can be San Leandro PD, San Francisco. We can reach out to them. It's the same thing, and they give us everything that we need.
What you're telling me is technology is helping us.
Yes.
working decades for it, it's helping us, okay. Very good, so what do families, public at large, need to tell 911 dispatcher when they call, okay, we see something, what do we communicate? How do we move this forward? How can families best communicate and advocate for to the officers and team members? To the point, I know when times like these, we all get emotional, we sometimes talk too much, sometimes we freeze, we don't know what to say. What is your advice to all of us?
Well, when you call 911, dispatch is gonna know where you are, if that's the call you make. And they're very well trained to get the information they need. They're used to dealing with people in crisis. And they'll lead you through the questions that are very important. If it's not 911 non-emergency, the same people are answering those phone calls. So they'll be able to kind of direct you through the information they need. And usually in the order they need it. So you might want to get to the very end of the story. They're going to ask you what your location is and get that information. But our dispatchers, any of the agencies are very well trained to elicit that information on the phone under a lot of stress.
I'll just add, say what's happening, what the issue is, that they're in crisis right away, because that can set the questions in a different direction. Just speak to it, and then if you have someone that is frequently experiencing crisis or something like that, creating the relationship with the police department and their special units beforehand can always be something that's really helpful, so.
Yeah, just to add to that, I think it's really important to stay calm as possible, because a lot of questions are gonna come at you, and it's really important in these calls that the dispatchers get as much information from you as they can, especially when it comes to safety. Is there any weapons? What symptoms are being displayed? How does this person react around the police? Is there any previous history? The more information we get, the better it is when we respond. And to add to that, I'm not sure if Livermore or Pleasanton do it, but the Dublin Police Department, we have a special needs registry that's completely voluntary. So if you choose to do so, if you have a child that's under the age of 18, it's basically a snapshot of who the child is. Physical description, what do they do when they're experiencing an episode? Do they run? Do they run from the police? How they act around the police, or the things that trigger them? That list is reviewed annually. If someone reaches the age of 18, we purge it. It's only accessible to first responders. If you have an adult that's under conservatorship, they can be added on there as well. But it's a good resource to have. It goes into our database. So when these calls do come out, we have information on how to deal with the issue ahead of time, in addition to what we would get from the person that's calling us.
Okay, so I have a question here. I am gonna ask after all. We've been told there are some police departments in California that only 5150 a person who has been accused of a crime. Is this the case in any one of our cities?
No.
So there are some police departments in California that only 5150 a person who has been accused of a crime. Is this the case in any one of our cities? Okay, I expected that to be no, but I had to ask. Okay. I'll leave at the end, I'll leave open to the comments. I'm shortly gonna turn it to all of you. One more, there's two more questions left. Do the police departments work with the county mobile crisis units, okay, MET, mobile evaluation teams? If yes, and what capacity and how? I mean, we heard that each police department has their own units and there's a lot of cross communication. County itself has, first we have nothing, and then we have all these services. And we from NAMI, when people come to us, right, and I can assure you as a consumer myself, you call a number, I call 988, and they try to question me, are you okay? Are you gonna commit suicide? I go, no, this is not about me, but I need help. So a lot of services are geared for consumers, but then the family calls, we're trying to get the services as fast as possible. So are we utilizing in our Tri-Cities some of the county services?
Yeah, I mean, I think both chiefs spoke to it, but after hours, sometimes yours is the Met team, right? So the after hours is cat team, so. But the challenge is that it is a long wait sometimes. Yes. But
Yeah,
we
after
definitely will
hours.
reach out to them if they're needed after hours.
My plea here, and I would let the public speak to this, right? A lot of times with mental illness, especially serious mental illness, evenings, nights are crucial, okay? They can't sleep, they get in trouble. And their families don't know what to do, but, please go ahead, here's things.
Yeah, I'd have to follow up, but I think, the community assessment transport team, they were gonna do a pilot program with 988 for after hours response, and basically a call will be made and there would be an over the phone interview to diagnose if a CAT team to be activated. But I'm not sure where that's going. I knew that was a discussion as of a few months ago.
Okay, okay. So our goal here is to make sure public knows where to go, what to do, what the resources. A lot is happening, folks. There's a lot of money, whether it's the housing or the police or the support. Sometimes things are not coming together fast enough. That includes even treatments, facility, everything is happening fast, but we get impatient because these are our loved ones, okay? Every day counts, every moment counts. So we at NAMI will try to bring the knowledge, the education together. I don't think anyone would agree here that the system is broken, okay? We agree that the pieces don't work, and I said it several times, police officers are the front lines, and over the decade, I've seen how they've turned and then learned. All of us are learning as we go, so I really wanna thank and applaud all our chiefs, first of all, the department, and really honestly, I just wanna applaud them because they've been there for me. I don't know about all of you, but we'll hear shortly. I'm gonna end with one question and we'll maybe talk about this later in the meeting. What can we as NAMI Tri-Valley right now, okay? What can we do to support our police department's efforts in psychiatric emergencies? And I'm looking at both sides, okay? Both from the leadership, people who do the work. What can NAMI do for you? How we can be the go-to group people to communicate to, especially the families, public at large, but families specifically, because people cannot speak for themselves in psychiatric emergency. The families are taking the brunt of it. Okay.
Yeah, I would say it encourages any members to be honest and cooperative with law enforcement during crisis where they're trying to help. And I think what's really important, especially with your organization, is you help advocate for additional treatment facilities in the community that are not part of a jail setting.
Yes.
I think that's huge.
Thank you. I try when they're not that sick. We can talk to them sometimes.
So I actually asked the team this question, and I think it was outreach and information sharing, and whatever the before the crisis information that can be shared. And I'll let you all speak to what information would you like to see before the crisis? I know you're not a case manager, but say someone lives in town and they're like, hey, we do struggle sometimes, I just want you to know my son, daughter, husband, wife.
Sure, this might be specific to ARU, I don't know the other teams, but we will always take advice calls. From the community is always welcome to call, to ask to speak to ARU, just to explain what's going on with their loved one, their family member. And sometimes that does end up in us coming out and doing an evaluation. Sometimes it's offering referrals to county services or private services that the family might not know about. And a lot of times, just building that connection with us is really helpful, because maybe in a few weeks there is a crisis setting and, oh, wait, that family member called us. We actually have a lot of background that's really useful to us. So Pleasanton is always open for advice calls from family. Does that answer your question?
Yes, so information sharing when you have.
So talking about information sharing, I'm gonna fail with the forum name, and Marcia knows this, but I know when I first joined NAMI Okay, the first thing I did is fill out the form 1450, there's numbers, there's 4-digit number, I'm gonna. 1424. 1424, okay, they know the number, I used to know that number, now I have 4 pages on it. So at the beginning, whenever I did call the police officers, I had that. Have the summary of your case, your loved ones written, okay, if they're taking medication, what happened, just a quick bullet, something, not too much, right? Just so that, you're gonna be worried, you're gonna be anxious, have that, and it is not for the police officer on the spot. They take them to the hospital, they take them to wherever they take them, it goes with them. And trust me, I followed that process. That paper got lost. First person they hand them over. Sometimes they go 2, 3 over, right? So, we're working on the process. We all owe it to ourselves, to our loved ones to understand. So starting with the family, I would say, get the form you can find at NAMI-TriValley.org. No spaces, NAMI-TriValley.org. We have all the forms there, everything, so, by the way, I'm gonna also take a minute to plug in Marsha. Every other week, we're on a, support group, adult support group. That helped me tremendously at the beginning. I would go now if I could, I have evening meetings, I can't. But it's there for people. There, NAMI Tri-Valley, we provide, and we're here to support the public. Whether you're online or here, you have questions, talk to us. Like we said, we're not going anywhere. And the whole topic of mental illness, unfortunately, is very complicated. From politicians and out to the whole health industry, there's all different topics of that, and we'll bring it here to you one by one. My personal goal is next year to have a panel like this for housing. A lot of money is going into housing, but unfortunately, it's fragmented. So on that note, I'm gonna open up, we promise you your questions, whether it's online or here. I'm gonna turn to you. If you have a question, just raise your hand in the room and we'll start there, okay?
We have postcards.
Yes, okay,
Do we wanna have people hand in the postcards and?
okay, so,
Anybody has a question they want taken for you? Also, let them stand up there.
yes, if you're ready to ask questions, you can raise your postcard. You want me to read it for you, or you can ask your questions, we'll do it either way, okay? So, just raise the postcard, raise your hand, and I'll come to you with the mic.
You want to do it?
Yeah, go ahead. No, go ahead, if you don't mind, I'd rather you speak.
Could you please discuss de-escalation training and who receives such training and who might that be available to, including the public?
So de-escalation training is, it's actually a mandated training that all police officers receive. And who receives it and what was the other piece?
And is it available to others? You know, I'm assuming the police force receives.
Yes.
Training, obviously, these folks.
Yes,
All
all
but
police
it's
officers.
available to anyone else as well,
Anyone else?
the public.
Oh,
You know, especially maybe a family member or somebody who's struggling.
right. So de-escalation is a verb, and sometimes it's a noun, and sometimes it works and sometimes it doesn't. And for, it depends on, for us, we're talking crisis only here. In a crisis, we are using different language, trying to understand, and so all of the training comes into play. Pre-speaking to the family, might de-escalate it in that, oh, they know who Julie is, they know Ryan. When Ryan comes now in the crisis moment, then, you know, having that relationship is probably gonna de-escalate it just because they have a relationship. It's an interesting question in, how do we do that for the public? How do we train the public on de-escalation? That does not happen right now, but it's an interesting question.
So we do offer a citizens academy. Can everyone hear me fine without the mic? Oh, I'm sorry, okay. So we do offer a citizens academy that often touch on various divisions and departments within our department. And it's a great opportunity if you're ever interested in seeing what we do and what we offer. Our different teams can speak on that. I wouldn't say that we offer that directly, that training, but it kind of gives you a better idea of what's going on, kind of like what the chief said, was that it's a two-way road. So we can only do our best to have people cooperate, but in reality, if they're not willing to meet us there, then we're never gonna get there. So it's just expressing that empathy, that understanding, having people, we're just meeting them where they are, you know, and trying to get to a safe conclusion to whatever that's going on. So it's a normal thing for us as police officers to go to, this highly critical, highly emotional scene. And so whether you're a mental health professional or you're a police officer, even on the street wearing a uniform, I think it's in our training, it's in our nature to kind of bring people down. And
Does that happen more than once, like CPR training, you have to,
Yes.
hurry up it? I know.
thank you for your question.
I think one of the things that an important piece of it too is how much time do you have? Do you have time and distance? We're using it. That's a no-brainer. Sometimes things are escalated and you don't have the time or whatever, you know, it just makes it more challenging in those situations. But if we have time, we're taking it. And if we have the opportunity to wait people out or try different things, then we're gonna do that.
And just to piggyback what Chief Avalar is saying, that's the great thing about our units is it allows us that time. Patrol, they do a wonderful job. They are trained to the best level, highest level of training. They all receive it, but on patrol, it's very similar to speed dating. Because they're going into a house and they got 5 other calls behind them. That's what's great about our units is we can go in and we can spend as much time as we need to de-escalate, find the right resources and get them to the right location and help the family out and answer the questions that we can do or answer the questions we can answer. So time is a big element to what we do because you can't rush mental health. That's when you run into problems.
Totally agree. One of the questions we got is, what does it take to become a member of the crisis team?
So as the newest member, there was testing. Yes, I did. It was very traumatic, actually. No, there was just an interview process, and a lot of it goes back to who you are as a person. You know, are you a good fit for this team? And actually, we just spoke to that because we just lost a clinician not too long ago. You know, we're a very small, tight group. So first off, you have an interview process in order to be selected. Not only that, do you have that personality type to connect with the team, and not only that, the community, most importantly. And so usually there's an interview process. It kind of follows a chain, and there's usually a selection for that. Sweet home. Yep.
If you're asking how to become a licensed clinician, it starts with 3 years of graduate school following your bachelor's degree, and then 3,000 hours of supervised experience working in various populations. And then you pay a bunch of money and you take a bunch of tests, and then you too be a licensed clinician on a crisis team. But like Ricky mentioned, I think a large part in becoming a part of the team, aside from like the paper credentials, is having a desire to connect with people in that way, a desire, especially for the officers, of wanting to try a different approach, a non-uniformed approach, want to see what that's about, trying to solve problems in the community. and just like a deep level of empathy and wanting to connect with people in a different way and being willing to, yeah, work together. And I love our team. I think we have a really strong bond and are able to work really effectively together.
I think if I could just add to that a little bit, one of the things we look for in the officers are experienced officers who are very good with their communication skills and also not easily frustrated, because the system is very frustrating, and they can attest to the fact that they probably and sometimes go out dozens and dozens and dozens of times with the same result. And then the next time they finally get some success. And so they have to be able to keep coming back and trying, not get discouraged, and work under a lot of stress. And then for the clinicians, I think one of the biggest things for us is to find a clinician who, after going through all that, doesn't want to sit in an office 8 to 5 in a sterile environment and do treatment. They are willing to get out in the field in the cold and the rain and the weekends and the evenings. And so this is a new field emerging, and I think that's a critical part, is to find the people who actually want to get out in the environment and work. And we've been fortunate to find some people like that. But that's going to be the challenge going forward, as we try to find more who are willing to do that.
Thank you. So, hold your questions. We have a lot of them and I see rates going up, but we're gonna right now get a couple of questions from online. I want to include our people online. They cannot speak, but they're gonna ask questions. Yeah, Marsha.
So we've asked Zoom viewers to put their questions in the chat, and can I do two?
Go
Is
ahead.
two okay? No? Okay, the first question, under what circumstances would you suggest that families get a restraining order?
So that's a great question. It's a very complicated question though to answer also. I think people have this assumption that restraining orders, they just mean that if you call someone and they just go to jail automatically, when that's just not true. There are stay away orders where a person has to stay away 100 yards, or move out orders, and sometimes there's peaceful contact. So I like to leverage that for people that are experiencing, say they have someone that's at home, and say it's a child, and they're trying to get them to get help, and they're just not going with the program, but they're suffering from all these mental health issues, or sometimes substance abuse. I like to leverage that as, hey, you need to protect yourself. So getting a restraining order shouldn't be a scary thing, but it does offer opportunity and avenue for maybe diversion, or say they do have a mental breakdown, now someone's getting hurt. I mean, at least they are served, at least they know, hey, these are the boundaries that are being set. And sometimes that's a motivator for people to get treatment. So it is an option. I don't want the community to think, well, I'm betraying my family member, or that it's just something that's wrong. I would highly recommend that. It just offers a level of protection, so.
I would just say, I mean, a safety issue. I mean, that's something that is, no one should stay in a dangerous situation.
Next question, Marsha.
Okay, next question. Is there a number to call for ARU advice? Hold on.
Sorry. Hey, yeah, if you're just looking for advice, 911 is not the answer. Just the non-emergency line, so for Pleasanton, it's 931-5100. And just dispatch will answer, or Reynolds will answer, and you just go, hey, I have questions about mental health regarding either themselves or a loved one. And I'd really like to talk to one of the members of the alternate response unit And then they get the information, they dispatch it to us, and we'll call you, or we'll meet you in the field and answer any and all questions that we can answer. And it's a great avenue for those that are trying to live, work, or be with someone who's suffering from mental health, right? Because a lot of times you don't have the answers, right? And that's what we're here for, is to help guide you in the right direction and get you to the proper resources that you or the individual needs.
So anything different in Dublin or Livermore?
As far as device.
Yeah.
Yeah, so for Dublin residents, our behavioral health units available to you, 925-833-6670. Just ask to be transferred to behavioral health, and they'll be happy to answer your phone call.
Very good. Very good. So for the next question, we're gonna change this up a little bit. Now we're gonna have
Okay. You have your hand up, so sorry.
Hello, my name is David. I work for Bay Area Community Health. I'm the lead community health outreach worker out here in East County for the unhoused population. So I know Ryan and Ricky and everyone here. I don't know the chiefs yet, but I'll introduce myself after. So how would you guys go about improving resources out here? Because each time myself and my team meet someone out there in the field, and I've been doing this for almost 2 years. I have my bachelor's degree from California State University, East Bay in public health. There's a lot of stigma around mental health, and there's a lot of mistrust. So the patients I meet, clients I meet, they don't want the police to get involved. So they want health workers to come out. How do we build that? How do you guys think we should build that trust with our community members out there in the unhoused population?
Build with the police and why?
Build with the police, the health worker, and then the patient / client. How do we all work together to get rid of that stigma and get rid of that fear? Oh yeah, they just wanna take me to jail and put me in a mental health institution.
Well, there are resources through Access Health and some other things that are healthcare, aside from police, but for Livermore, we have homeless liaison officers who go out and work in a pair, and they've been doing it for a long time. Greg Carr was one of those officers before he joined the med team. So, I think in Livermore, we have a pretty good reputation as far as that goes. And the fact is, building those relationships over a long term, break down those barriers. And then, if somebody has had that experience with our HLOs, then they can share it with other people. But, I think that's, I think we both have to come a little ways. And I think by putting our HLOs out, and the fact that they are dealing with these issues and really focused on connecting services and not taking people to jail, goes a long ways.
I'm gonna go to the people who raised their hands. We still have questions.
Hello, my name is Shireen. I grew up in Pleasanton. I'm a clinician as well and was a mobile crisis clinician for San Mateo County. I have a loved one who has been struggling with mental illness since he was 14 and he's 41 right now. How do you recommend building relationships with local ARU teams and PD with a family member who's a clinician so they can get the help they need?
I think Julie said it a little bit earlier, but filling out the 1424 and then creating it so that when things are happening, and I will let them speak to them, but when things are happening, it's not the first time meeting, especially since it's going to happen again. And then identifying if there's any fear for safety of people in the home, all of those kinds of things. So it's that relationship and that information sharing.
Yeah, we spoke a little bit earlier, but I want to stress, not just to you, but to all of the family members in the room. I do personally understand what it is like to have a family member with severe mental illness and know what an impact that has on your family, as well as your like concerns for safety for your loved one. Given that, I think it is necessary to understand what a high level of criteria it does take for us to take away someone's rights to put them on a 5150. So what you might consider to be very behavior, maybe somewhat dangerous, property destruction, threats, things like that. A lot of times I do understand, trust me, I understand the concern about that, especially living with that on a day-to-day basis. A lot of times that does not meet the full criteria for a 5150. So with that, using something like the 1424, having that filled out, having established a relationship with the team prior to maybe multiple contacts where we can see this deterioration in behavior, that is more useful and might push things over the edge into a 5150 because I take putting someone on a 5150 to be like an extreme responsibility. I think that the criteria should be high. We are taking away someone's rights. And so the threshold for me to do that is very, very high. Even though there might be other concerns and I understand that. Do you have anything you want to add?
I mean, basically what was already said, I think kind of doing those kind of contacts where we can have an idea of their kind of baseline of functioning really helps us be able to see if they're decompensating. That's been really helpful for my officer partner and I to be able to go out to homes when the person's not in crisis, do an evaluation to kind of figure out, hey, what's their baseline of functioning? Like, what is the day-to-day like? Some people are just escalated all the time. And then when they really reach that peak, we know when it is happening. Not only based on what you're communicating to us, but based on the fact that we've had prior interactions with this individual, it also helps us be able to build that rapport when the person's not in crisis and then interact with them when they're in crisis. I think it also helps have more positive outcomes.
What's worked for, I think, myself and Ricky a lot too, is being very straightforward when we come on scene. As some of you may know, when someone's in crisis, a lot of cops show up because why? Threats of violence, things are being destroyed in the home, walls are being punched, whatever it is. And so when we are called to a scene and there's 3, 4, maybe 5 cops on scene, fully dressed, fully uniformed, and it is escalating, and I'll immediately reach out to the individual, let's say it's Ricky, and I go, Ricky, do you want all of them out of here? Do you want me to tell them to get out of here? Yeah, get them out of here, I don't want them here, it's an escalate, the uniform. They know nothing about the person, it's just the uniform. Okay, guys, I need you to leave. And out the door they go. Obviously, there's not a weapon or anything like that. Guys, I'm gonna ask you to leave, and they walk off. And it's like, oh my God, who's that? And then we start a conversation. Most times, because we're not in uniform, they don't know that we're police officers. They think we're all mental health clinicians. And I use that. I'm not, right, Julie? I'm not, but that's what we use that. We use that as a tool. We have many different tools that we could use when we arrive on scene to de-escalate immediately. And that's starting off with that. I love to kick out police officers. And it works. It works. But it is finding those little things that work with people, right? So
I just wanted to add that, I understand in my opinion, there is a broken system, because I have put people on hold and then psych emergency just lets them go after 30 minutes. So in my case, we can talk personally offline if you want, but I did have to put an APS report against them. I don't know if the crisis team had written an APS report, but it was confirmed that he put hands on both of my parents. So now he's homeless in Dublin, wandering around, unmedicated, psychotic, and I'm the one that's having to partner with Alameda County Behavioral Health, facts, and access. So there was criteria. I'm just saying that it seems like based on each county or city, there's some restrictions. I know officers do not enter homes for that reason, the law that you mentioned, sir. But it is frustrating coming from a clinician and a family member. The person has to literally either commit a crime, end up in Santa Rita, which has happened, or end up dead, or kill a family member. And I've worked with NGI clients, so that does happen.
It's very frustrating. I completely agree with you that we ourselves have put people on hold and they're out in 30 minutes. We're like, whoa, what is going on? And we've had to replace people back on holds. And then we've filed complaints with the hospitals where that happened. And we cite very specific things and incidents and saying, hey, this needs to be addressed on your side, so right? My recommendation would be communication with everybody who was involved. And, yeah, and I know it's not that
It's
easy.
been hard. I've called several times and haven't got a call back.
I'm sorry.
So we can talk offline, but like, if you want the, clinical background, I can give you all that from age 14 till now. So that we can avoid the arrest or someone getting hurt.
Yeah. I'll be happy to see.
Thank you.
Good evening, everybody. My name is John Bauer, I live here in Pleasanton. I'd like to first start off with a couple of comments. I'd rather sit at the our son, it's been about 7 years, was spinning out of control. Our family contacted the county, the police, the sheriff, hospitals, everybody, and I will say this, NAMI's the only one who picked up the phone. They provided a lifeline, so to speak, for my wife and I. 7 years ago, I will say that certainly the Pleasanton City Council did not have an appetite to establish an alternative response unit. You have the conversation at that time was, well, the person must be on drugs, arrest them, take them to Santa Rita jail. Nothing about, that the person could be in crisis. So we've come a long way in 7 years. City councils have changed. I know in Pleasanton, this was a heavy lift to get the ARU established. There was, let's just say, some city council people who were not on board with this alternative response. The other comment I'd like to make is there's a book that NAMI promotes, and the title of the book is "I'm Not Sick, I Don't Need Help." It's written by a gentleman by the name of Javier Amador. He's in the industry. His brother, had mental illness. He was schizophrenic, and that's the biggest challenge. That was the biggest challenge with our son. He thought everybody else was screwed in that head, and that he was the only one with his head screwed on straight. So when I read that book by Dr. Amador, we could just put Jacob's name in there as a substitute for his brother, and that was him. He was on secret assignments for the CIA. The Russian agents were trying to kill him. There were 747s tracking him. So I would leave the police and the clinicians. And the only thing I can say is the people, they are in a different universe. I mean, they might as well be speaking Klingon. Our son, he was, he's a pacifist. We went to the Pleasanton police, and at the time, they, stated, that, Pleasanton police was the most highly trained in CIT. This was in 2018, and 3 days later, he's dead. So the question that I had is, when family members do contact your department, And they're stating that they're very concerned about a family member who is struggling with mental illness. But the person hasn't broken any laws. Does your department, put these family reports on your radar so that if you do encounter somebody that is struggling, that they know what they're getting into?
Hold on, let's see.
First, I want to say thank you so much for sharing your story. Yes, I would say that when family members call, of course, when there's no crime being committed, even if there was a contact with police, we get emails and printout notes on our desk and in our inbox at the station all the time of officers who are out and about and they know that, hey, this family has either requested it or maybe not, but they know that this might be an ARU referral. So we, our department is really great. All of our officers know. I think by now that if they think something is up as far as mental illness, family needing help, that they're gonna let us know about it. And that's something we, stay informed.
I also want to say thank you for sharing your story. Met and Livermore does something very similar. We have a variety of different ways of getting referrals. Patrol officers will email us, they'll literally come talk to us, dispatch and forward incident numbers. That means that police may have never went out there and made contact, but they called 911 and asked advice. We'll get those forwarded to us. Family members often come into the PD lobby, and that's how we'll initiate contact as well. So there's a lot of ways to get advice, whether that's over the phone or in person, as well as in place notes, so that sometimes we'll flag a person so that officers go out and immediately, as soon as they look up that person, it comes in and it either says what might be going on, what family has reported, it might have your number if they want to contact you, if they need that person out in public before you even interact with that person to get background. So there's a variety of ways to get extra support for that person.
Things are changing monthly, let me tell you, that's what I was saying earlier, we're grateful, but the whole system needs to come together. And one point, we're gonna do the whole all the groups that are involved. But I wanna make a quick announcement here. We done one month, battery run out, but I have one, so we'll be running around. I wanna get all the questions online. I still have your cards. We're gonna be here together, making sure we answer all your questions. Just in case. Did you have one question?
As best we can,
Yes,
yes, within the time. I'm just gonna grab one. I haven't really studied what's here, but are the officers aware that they can submit care court applications on behalf of those that qualify for care court? That qualify, excuse me. Care court is such a great pathway to self-sufficiency.
Care court, anyone? I know a little bit about care court.
Yeah, I'm not sure, that care court is being used on the other end. I'm not sure what happens maybe but I haven't, seen any, applications for care court. So I will.
Anyone here knows?
So we just met with one of the primary leads of care court, at Alameda County. And care court is being used in a really interesting way. Yes, I think our team is very aware that as clinicians, mobile crisis officers can submit petition directly to care court. The way it is being used in Alameda County is that I think they said something like 97%, do not quote me on that number, but if the majority of their care court petitions are actually internal to ACBH. And the way that happens is usually someone enters into the ACBH world through a referral. Alameda County Behavioral Health, so the county system of mental health services. So someone enters into that world through a referral, an outside referral. And we are achieving that in Pleasanton. We are making what are called IHOP referrals, in-home outreach team referrals. The county operates has different operating areas and contracts those IHOT services out to different providers. In the Tri-Valley area, we have Abode, who is the IHOT provider out here. There's also a Fremont team, and then, oh gosh, it's slipping my mind right now. I think Bonita House is also an IHOP provider in like North County. But once that person is engaged by IHOP, if they feel, if that team, which is like a 5-person team, if that team feels that this person does qualify for care court, they will internally make the push and do their own petition for care court. And that is where most of their to date, most of the Alameda County care court petitions have come from within within their own system, if that makes sense.
If we did refer it, goes to Dublin.
Yes, if we did make a petition for care court, like directly do the process to petition for care court, it would get sent back to IHOT anyways, because a portion of like qualifying for care court is a established bona fide mental health history and attempts to engage in outpatient treatment. And so we could do all of that documentation and make that case for this person through care court and do that petition, they're likely just going to send it back to IHOT anyways. So we have found it to be more effective to just, if that's where they're going to start internally, then that's where we will start as well. And that's what we were advised to do by ACBH and by a primary, I don't know, player in care court.
Yeah, can I just say one thing? I feel like when we first started talking about care court, it seemed like a really great avenue because of that threshold for 5150 is so high. And the reality is we 5150 someone and they're out in 3 hours. I'm being generous. And so the challenge is, but care court has this path to treatment and to maybe someone getting help. And I don't know if we're there yet, and I might be, I haven't seen it yet. I would love for that to grow, for sure.
I'm gonna second you because I'm living through it. And personally, we're going through that situation. I can tell you, well, first of all the family members, watch out, next year, we're gonna bring you a speaker. We had a care court speaker with a consultant that came, said what it was about. We'll bring one next year. For Alameda County right now, I just know the stats, we're just under 100, it's 90 some people enrolled in a program. There is a big period for evaluation. It's not easy to get in, but once you're in, and the maximum this year, they said it's 150 for the program. They geared up really fast, working with them currently. So that said, it's also a voluntary program. They cannot force medication, they cannot force even the court, everything is voluntary. So everything we're doing with the full wraparound service that you heard the name of both or BACS, with the BACS is the service provider for Alameda County Care. Okay, so again, we're watching that, it's no miracle answers there. But again, things are changing slowly. If you have a loved one, you're just not moving fast enough, but that's what we have. So I'm gonna move this along. What support is there for non-English speakers? Maybe for different cities?
We all, again, mandated, to have access to translation services. So, yeah, every police department, dispatch, anyone, we have access.
So they can actually ask someone to come with them to translate?
So we use different services, sometimes phone, sometimes like FaceTime type thing.
Yeah, we're Spanish speaking officers. is another one. And then a great resource for Spanish speaking only would be La Familia. That's a great resource for Spanish speaking residents. They will connect you to mental health, they will connect you to other resources so that you can get help. You are not alone.
The translation services through the police department are usually pretty good. I've actually been able to do assessments on people who speak sign language through like do like a FaceTime and they actually sign. So it was really interesting process because that's I think an area for a lot of people that are kind of forgotten about, and they also go through crisis, so that's something that's also utilized, so we definitely have a lot of resources at our hands.
Julie and I have 3 cards all together,
Army
but you
Day.
raise your hand, you jump in the line.
Can we do a couple more of these once?
Wait.
Yeah, after Laura, yeah, we got quite a few, yeah.
Let's give priority to the.
There, okay. As a retired, former school nurse, I had some interactions with SROs that weren't always to my liking. It seemed the response to suicidal behavior in teenage girls often is criminalized, and I think it was a very traumatic event. Being handcuffed to a wheelchair, waiting for an ambulance to come, without consulting the clinicians in the high school and without consulting the school nurse who was on the premises. I'm hoping with all these wonderful changes that I am retired. I'm hoping that is no longer happening, that there is that very aggressive, kind of police response to, just a threat, like my boyfriend broke up with me, I want to kill myself, and then end up going through this whole, horrible traumatic event. I guess I'd just like an update to hear what's going on in our local high schools.
And embarrassing too, so yeah, there's a lot of.
Exactly.
Yeah, and again, I can speak for the alternate response unit in Pleasanton. We go out of our way to not do any of those things. And as a matter of fact, it always seems to happen this way, right? School gets out at 3:15 and we get the call at 3 p.m., right? And a lot of times what's great about, again, alternate response units, we have unmarked vehicles, right? So we don't show up in a police car. Obviously, we're not dressed in uniform. And also, if there is not a threat or the individual eloping, we'll transport, and they walk out with us. And we yes, to the emergency room. We will stay with them until either another family member shows up, or until we can stay with them to as long as possible, to the point where they're now being seen by staff.
Not handcuffed.
Not handcuffed. I know what you're speaking of.
I mean, it happened.
No, it did, absolutely, that was.
It was horrible.
Yeah.
Very traumatizing.
Yeah, for sure, and our objective is to make sure that does not happen. And as a result, we don't do that. We don't handcuff to the chair, and we don't escort them in handcuffs outside. We go out of our way to not even allow an ambulance and or fire truck. If they're needed, they're needed, right? But if they're not.
I would agree that it would be required, if you were really concerned that someone was going
Right.
to commit suicide
Or-
right then and there. I
Right.
mean, that's happened too, but
Right.
that wasn't the case, and that was just the standard behavior.
Yeah, because it was, they're a danger to self or others, so we have to handcuff them. That was the beginning of my career. Not anymore.
Okay.
Yeah, not
And
anymore.
that's true for all the high schools in this valley.
I can speak to Pleasanton, and I'm sure.
Similar to ARU, we do the same thing, we respond to all of the schools. In fact, when our team got basically manifested a year and a half ago, we went to all the schools, we met with the counselors, the psychiatrists or psychologists that were on site, as well as the principals, and built that rapport before crises started happening. I think in Livermore, we're very fortunate, we have really, really amazing SROs, we have amazing relationships with most of the youth, and in fact, many of the youth ask for them to stay the whole process. We also will transport, whether it's involuntary or voluntary. So if a youth wants to go seek voluntary treatment, we will bring that youth to wherever we can get them in, and we will sit with them until they're admitted. Obviously with parental consent, and same with involuntary, we'll often drive them to avoid the hospital, or maybe families worried about the hospital bill or the ambulance bill. We will try to do everything we can do to mitigate that process.
You hit a lot of nails on the head with what you said, and
Okay, we have a raised hand.
Thank you. My question is, when someone is in crisis, how do you find out about their access to weapons? And do you sometimes have to submit a request for like a gun violence restraining order, or let the family members know about that process, or at least talk about ways to make sure that that person in crisis does not have access to a gun to harm themselves or someone else?
I'm reading by the seat. Well, they do it every day.
Great question. It's part of our policy and procedures that if there is a person in mental crisis, they end up getting on hold, and we will assess to run weapons register too, so typically firearms. If they do have firearms there at the house, we would secure them and keep them for safekeeping. Sometimes there's family members that have firearms that are not registered to the person, and maybe they have access. So we put the public safety at the very top, and so we always make that recommendation of, hey, we can take your guns, or hey, can you secure them somewhere else at a storage? We just want to make sure that you're safe. And sometimes there is no allegation of threats, we just don't know, and we want to make sure that everyone's safe. So being placed on a hold and actually being evaluated does prohibit you from owning and possessing a weapon. So we do have a risk assessment that we go through, and we just want to make sure that everyone's safe.
Is it true that it's 5 years? If they're hospitalized for 5 years, they cannot own a gun, or is there no time limit?
I believe it's.
It's 5 years.
5 years.
And it has to be involuntary. I worked at John Muir.
Yes, okay, that's what I was told, I was confirmed. Okay, one more hand and I'll give one to Marcia.
First I want to say thank you for coming out. I'm a long time Pleasanton resident. And 10 years ago, I helped form the special needs committee with the PTA here. And I know how hard it is when someone says, hey, let's have a great idea, to actually do it, to follow through and go through all of the hurdles and keep it going is really awesome. And just hearing the program in action, also having gone through the school district, sometimes we have programs that are just there in name only, just to say we have it, and it seems like that's not the case. This is a thriving program, so kudos and thank you. I do have a very specific question. My daughter's now 20, and a number of years ago, I heard about the Pleasanton Special Needs Registry, and I put her on it, and it was not a fun process. And it shows that you're upgrading the registry right now, and that it'll be up in the fall of 2025. I was wondering if there was any appetite to have like community input into the usability of the functionality of this resource.
Yes.
Okay. I'll sign up.
I can answer that. So we're actually our unit is working with crime prevention, who's putting that on.
And there are criteria that they're trying to meet, and we're getting ready to launch that. So part of that process is we need to vet the information. So as information is coming in, we're going to evaluate it, confirm. We just don't want to have misuse of that system. Say a friend's doing a prank, or maybe it's just not accurate information. But we can definitely connect afterwards, and I can give you contact information to Officer Montgomery, who is heading that program. We are working with them. So yeah, I'd love to connect with you.
Just one thing I'd like to piggyback on. If there is somebody that is listening, maybe online, in your department, let's say you're not from Livermore, Dublin, or Pleasanton, and you have a child who is special needs, or an adult who's special needs that's in your home, I am going to strongly recommend If you don't have a registry, call your local police department non-emergency line and let them know. And because they can put it in the database and connect it to your house specifically. And you say that, hey, I have a special needs child and or adult, these are their triggers. And can you please, if we are ever called to our home, please have that in your database, so when your officers are responding, that they know that they're gonna be interacting with an adult and or a child who's special needs, because that is very important to know.
Okay, we're gonna keep going. Okay, I'm holding 3 cards from the room, so.
And then I can do Zoom.
After.
We have great questions on here.
One's in the room, so, and I've been holding these for a long time. So, there was one question about, what kind of bilingual services, so we'll kind of put that one, in the parking lot to answer. But the question that I think was very relevant to some of what was already said was, and this is a multi-piece, are there any metrics of the effectiveness of the unit in the Tri-Valley? Being on the city council, we get biannual reports, and so we do hear the statistics and metrics. And so I'm gonna let them respond to that, but I can attest to that we do follow. And it has been, many of the voices in the room today led to having an ARU in Pleasanton. Many of the voices who have spoken, I represented their voices, I represented their stories. The ARU came from a need in our community, and it's been amazing. It really has changed dramatically the outcomes of our loved ones. Many of us in the room have loved ones who have suffered with severe mental illness. So the metrics, we talked about our schools, our 5585s, as Laura Danielson, school nurse, Amador school nurse, her stories were represented. And what we have today is so much better for our students and our families. So I'll let you answer that, but it's question. Does it seem that there are enough officers and clinicians currently on the teams? There will never be enough. But when we talk about the success of our crisis response unit, I'll speak for Pleasanton. Funding is always a concern. It's not, it's a big funding need for the program, but it has been identified as an ongoing. It started as a pilot program. It was so successful that it is no longer a pilot program. I believe it will continue. We need continued advocacy. We need to make sure it continues. So I'll let that answer, but let me finish questions here. How many years back do records go that are available to the department? 7 years, question, or more? Does the system include records of hospitalizations from decades ago? If not, are officers or mental health team respondents allowed to go by records provided by families? We had some discussion about that already. Would officers benefit by having a shorter version of the mental health summary from family? Again, that wasn't addressed, but I think it's worth repeating, so that question's been completed. Can anybody?
That's a lot to unpack. I'll speak to metrics. I was asked a question recently, since our behavioral health, was found and hasn't reduced calls for service. And that's kind of a hard number to quantify. What I can say is that many of our referrals, which come from schools, which come from calls for service in the community where we know that someone needs assistance, it's been very successful, and most people have been very accepting of the services. The school resource officers have reported that problems that have been occurring because kids are not getting services at home, they're not having to deal with those anymore at the schools. So that's how we gauge our success. Our behavioral health unit keeps track of all our numbers, all our cases. And they're doing a great service to the Dublin community. It's about community wellness is what it is for our unit. And what was the other question? Records retention?
Okay.
I think records retention depends on individual policies. Sometimes records have to be maintained for a certain amount of time, but I don't know, all our go on the same page with the years, you think?
I think things change as well, so.
Pass the mic to, thank you.
I think the intent of the question was, do we still have the information on the individual? So that we can help them with all of the history and, we, depending on, we all have different systems, now than we had probably even 7 years ago. I don't know about the sheriff's office, but, so updating the records would be helpful, and also, things change with individuals as well, so that's what really I would. Did you have more to add? As far as metrics, I did bring some metrics, but, the 5150s are way down, and I do wanna do a shout out to our, school resource officers, who also make a huge impact on the mental health and the treatment and the relationship building of kids out of schools. And if ARU is not available, they do the exact same process, and so everyone is on the same page. But school 5150s are way down. All 5150s are way down, and the calls diverted from patrol. There's, I can tell you the numbers. They probably won't mean anything. But for last year, calls for service for ARU 1,268, deferred from patrol 457, assisted with patrol, so a co-response 303, and then proactive engagement outreach 508. And a lot of times it's they have relationships built with individuals in the community. We had some significant heat issues last year. They were out giving water, making sure that they were all safe and providing services in that way, which of course before ARU we wouldn't have had the ability to do. So the metrics are speaking for themselves.
I'll just add, as far as the records go, we do have quite a history in our systems that we can refer to, but we would take any other documents that are available for us to review and see if it's relevant to our case. As far as our data, it's hard to tell because there's a lot of calls that have mental health components that are never really recorded that way. And so we recently, or in 2024, started trying to capture that a little bit better. So even if it was entered as a disturbance call, when the officers get there and they find out there's a component there, they will categorize it that. So we can get better data, cleaner data. Like I said before, I think we had 2,400 calls that related to that in 2024. And then our med team has responded since they started in 2024 to about 900 calls for service. And so that's a reduction in what patrol would normally have to handle. And then one of the other metrics that we capture, and I don't know the number off the top of my head, but the number of times they connect somebody with services, which I think is a big benefit, and that tends to draw down the numbers, but they are constantly making those connections, which is a level of success too.
Thank you. Thank you. This is the last one I will read, but before I do, we do have a resource of a lot of the resources available. City Serve and contact and hours, and please feel free to pick one up on your way out. And earlier someone asked where they can get advice. There are resources for help, and certainly NAMI has our support groups as well. So I always say with NAMI, my loved one was my father. My father, many years ago, went undiagnosed for 20 years. It was very difficult. It was very extreme. NAMI exists today to help families through what our family didn't have help with. So I always say, you don't know you need us till you do. So the last question I have here is an intense one. If a person has symptoms, bipolar, schizophrenia, anger rages, but has never gotten a medical diagnosis, screening to confirm what the problem is. As we know, Mr. Bowers identified his son Jacob. Everyone else is sick, it's not me. That was my father also. Everyone else, and he was good at convincing people everyone else was sick, but not him. So, because his primary doctor isn't aware of mental health symptoms, we're not getting support. What can be done so the person can get a diagnosis? That's a tough one. And I'm not sure that this is the right panel for that, but we'll give it a shot. Again, there are resources, and you can connect with NAMI to talk further about those resources. Does anyone have anything to advise for someone who has a loved one who is not acknowledging the illness and you got
It's a super tough question. I think one that probably we all deal with on a daily basis. Unfortunately, in California, most mental health services are voluntary, and once you're over 18, that person can select whether they want to go to a medical doctor or if they want to go to a psychologist to get an evaluation. So there's very few ways of forcing that person once they're an adult to go and get that diagnosis or to get that comprehensive assessment. You want to get an accurate diagnosis. Yes, their behavior may escalate, they may be placed on a psychiatric detention, and they may go to a county hospital, they may get a provisional diagnosis, whether or not that's a comprehensive diagnosis that's really gonna explain the intricate history that you guys have seen. It's unknown, right? And they may get prescribed medication and come out and never take it. So it's a very, very complex and tricky situation. Unfortunately, there's not an easy answer. I would say that if your loved one lives in your home and you have the ability to bargain or make some boundaries with them, residing in the house would be, hey, if you're gonna reside in the house, I want you to go to the doctor, get a medical evaluation and a psychological evaluation. So setting some of those boundaries to try to get that person help is very helpful. Calling mobile crisis to have them come out. Many mobile crisis teams are not gonna give you like a official diagnosis, it just depends on their role, but they may be able to give you further guidelines. I would also consider calling FERC or someone like that. Family Resource Center can be really helpful for family members, giving you some guidance on how to talk to your primary care physician, how to talk to the doctor, how to talk to your loved one, just depending on your involvement. And then if their behavior is really escalating to the level where you're interested in pursuing or looking into conservatorship, I would refer to an attorney and get some advice on that, because there is different types of conservatorship that can help you make decisions for your loved one if their behavior has decompensated to such a level that they need that intervention.
Okay, I'm gonna read my last question at hand. What are your opinions on the effectiveness of California involuntary treatment laws for total removal? For example, Code 5150, what changes would you recommend to this process since law enforcement is responding to the situation? Thank you, Star. Again, what would you recommend? How would you change 5150 process? We talked a little bit about it already.
You know, that's a challenging, because you lower the bar for 5150, and I will say there are a lot of times in my career, a lot, unfortunately, where you have, say, for example, a couple going through a separation or a divorce, and they're utilizing allegations against the spouse for the kids, and that's the danger. You have someone, you lower that 5150 bar, and now we have people just using it to get back at someone, or you take my word for it, they're crazy. So it's challenging. I mean, that's not gonna be an appropriate response. Or so for the police department, the bar has to be high. There's this in between that I talked about earlier where we can do so much better. I don't know how to get there. I wish I did. But there's a gap in the middle that needs to be addressed. The holds are temporary, and often it's just to get someone to a safe place But what's that next step? And, I'm a police chief, I wish I knew. Sorry.
I just wanted to clarify that these are just applications for psych evaluations. So where I feel like the system is broken is we can only do what we can do. We fill out the application, they go to a hospital, someone may clear them, you know, it may be hours. But it's just to stabilize this person. So say they do make it to a psych facility, it doesn't offer long-term care. We're just there to stop what's happening now, you know, and that their responsibility is to stabilize, it's not to provide that long-term treatment. So that's where I feel like it's broken, and we have this continued cycle that we're going through. We will want to help. And 5150 sometimes isn't the best option for someone, but it's the only option. They're gonna go to a county facility and it's the only option. And we're just trying to help. And the long-term care, that is a barrier. It is hard because they're not ready, they're not willing. There's just some difficulties with that.
Someone experienced a mental health crisis, they've dealt with this and they know what to say very often. They know how to work the system after a while. And so that's a struggle too. And so, and no, the hospitals are doing what they can as well, but I'm gonna give this back to you, you were gonna say.
Well, I was gonna, I started off with my concern that there's not enough services at the end of the line, and we see that. We see people on the street who are suffering and deteriorating and just getting worse and worse, and we watch it. And so the system's definitely broken. I think that, I don't think the criteria needs to change for police officers to do an application for a detention or 5150 hold, but I do think there needs to be more attention paid once that happens. And there needs to be a process to where doctors and judges are involved to make a determination on whether this person needs to be treated and if it's in their best interest. And so we need to find that criteria. We need to develop that system, and we need the care at the end of the line, because too often a lot of the population that's homeless at this moment, a lot of them are really struggling with mental health or alcohol or drug treatment or all of the things together. And we just continue to go out and see those same people over and over and watch them get worse and worse. And so we really have to get a handle on it. There's a better way, and we've got to find that. I think we're the front line, we're the Band-Aid, and we're doing a great job with that, or the team is. But there has to be something at the end of the line. There has to be a way to get people into treatment and get the care that they really desperately need.
And the reality is we're paying the money at some place. We might as well put it to where it makes a difference. The money's gonna be spent somewhere.
The system is broken, see, we don't know it, right? But let me tell you, Alameda County doesn't have the answer. I don't think many other counties have the answers, but no one can help if the person is not willing to go. If someone is willing to get help, there's a lot of things, there's a lot of options. But we know with SMI especially, serious mental illness, they're either in denial, there's addiction involved, it gets complicated, they got issues to help police officers because they're the ones who are taking their freedom, total denial. Families try, eventually families say we can't help it, that's the numbers of homeless is increasing. It's a pessimistic picture to draw, but our political situation current is not helping either. So things are not gonna get better. I can show you that, even the cuts and things. We're working from Tri-Valley. I work with Alameda County Behavioral Health. As a matter of fact, next month, Dr. Tribble is coming to talk to us. It's a tough challenge. There is no answer because they don't want to take person's rights away. I'm struggling with that. As a matter of fact, do we become a conservator? Do we not? How much do you push as a family? How much do you take person's life rights away? Did you have anything to add on this or?
On the 5150.
Yeah, just to add what was being said, I worked for years down the street from John George at our patrol station in San Andrew, and it's a broken system. And especially the not only if you're dealing with mental health issues, but what if you're unhoused as well? And it's freezing outside. You don't have anything to eat. So I've seen many people that we fill out the application to send to John George and they're out of there in 20 minutes. So they're out there in 20 minutes, they're still unhoused, they still haven't received mental health treatment. So now what do you do? So that's the real hole in the system is what are we doing down the road to get them into housing, get them the treatment that they need. So we're not relying upon the police to intervene to fill out these applications over and over and over again, which is not doing anything. I can tell you, for example, there was one night when I was a patrol ship supervisor working midnights, one of our unhoused came over and was experiencing a crisis. We had to fill out the 5150 application twice. We filled it out twice, about a total of 30 minutes in the facility. So they basically kicked him out the front door as fast as he came in. So that's a real, it needs to get fixed. It's a broken system.
Our heart goes out to unhoused people because if they don't have addiction problem, they'll start using something to just be able to survive. There's just so many problems and the system's trying to house them, but no true answers.
I'm back to Zoom. I would like to ask, we're not going to get to the Zoom questions. It's almost 8 o'clock, so I recognize that. Is there any way that we could relay or forward the questions? I mean, they're really good, to someone in each of the departments. We would love to hear back. Is that possible?
Absolutely.
Okay, great. I feel much better. Thank you.
The
Okay.
answers will probably be much better too.
Oh, there you go.
I just had a quick question. Do you guys provide assisted outpatient treatment, which is court mandated treatment in Alameda County?
Earlier when I was speaking about the path to care court and how we start that with IHOT. So there's a middle step in there from IHOT to care court, which is AOT. AOT is run by the county. It is required, but also voluntary. It's not crime if they don't follow through. It is a civil issue. I don't think anyone pursues that. It also, like care court, relies on the black robe effect of a judge told you to go do this, and now you must do this. Yeah, I don't personally know who the AOT provider is in our part of the county here. Maybe Abode, but that would be accessed again through the county, and that is an escalation from, again, starting with IHOT.
Assisted outpatient treatment, and I have to stand here and say, IHOT saved me. I owe it to them. And the early days, they sat with me, they called social services, they found it was incredible. Yeah. So it's almost 8 o'clock and I think just gonna. First of all, thank you all for coming, both online and in the room. I have to turn here and say thank you very much for your time, for your service. Thank you, folks, and I apologize, we should have had Dublin come with a crew too. We're learning, there is a need to talk, obviously, but I would like to pass the mic for like 30 minutes, 30 seconds. But 30-second summary, your final votes.
I just thank you for having us and allowing us to speak to the great work that's happening. The one thing I would say is plan ahead, make a plan, and so reach out to whatever city that you're in and get those services and the relationships built now before you need them.
I just wanted to thank everyone for being here tonight and for organizing it. I think it's a great conversation. I know there's a lot of problems and a lot of things that are broken in the system, but there's a lot of things going well. And if you look at the teams we have here that we didn't have just a year ago, 18 months ago, I think we've come a long ways in a short time, and so I'm looking forward to the advances and the improvements, and also all the people in the room who can advocate for the things that we know we need, which is that long-term care, more beds, more work at the end of the line. So it's encouraging. I'm excited to have this conversation, and I can't wait to see what's in store for it.
Yeah, I echo their sentiment. Thank you for having us here today. And I learned a few things from my colleagues up here as well. Great conversation. Like I said, when we started, I've been doing this for 23 years. We've come a long way as far as care and compassion and doing something about these issues, but there's a long way to go. And your organization could be there to help us and advocate for those resources that we need in the community. So we're not the answer all the time, because law enforcement is not always the answer for these situations. What we need is long-term care and solutions, not band-aids. So thank you again for having us.
So ladies and gentlemen, there's a partnership. We're all in this together, okay? We've got to work together. We got to support each other, and there's a lot of work ahead of us. Stay with us, give us your comments, and people you want to see, come visit us, topics that you want to cover, NAMI, trivalley.org. You can find everything you need there. Thank you.